Hello, thanks for joining today. My name is Melody Glenn. I'm an emergency medicine and addiction physician here in Tucson, at the University of Arizona. Thanks for coming to my talk today. If you could please fill out a QR code, use this QR code to fill out a survey, and that's how you'll get CME for attending today, CME or CE. So today we'll be talking about treating opioid use disorder in the emergency department and in the hospital setting. We'll start with just sort of talking about how to identify opioid withdrawal. It's something that we see all the time, but maybe we're not as familiar with the scoring systems used for it, the epidemiology of opioid use disorder, medications that we can use to treat it very effectively, making our patients' lives and ours much easier, and discharge planning. So quick definitions for terms that I'll be using a lot today. I use OUD for opioid use disorder, and I use MAT and MODE interchangeably. MAT medications for addiction treatment, and MODE is medications for opioid use disorder. They generally refer to buprenorphine, Suboxone, or Methadone. I often use buprenorphine and Suboxone interchangeably, even though they're not quite the same thing. Buprenorphine is just the mono product, and Suboxone is buprenorphine mixed with naloxone, which is not absorbed sublingually. All right, so let's start with a case to sort of make this more relevant, right? So we have this 34-year-old with cellulitis. He comes into the emergency department. He meets all the sepsis criteria. He has this abscess in his arm surrounding cellulitis, and he's going to be admitted to the hospital. So he gets his fluid bolus, he gets his IV antibiotics, and then he starts to get worse. You notice he has a tremor. His pupils are a little more dilated than you might expect. He's yawning a lot. He's sneezing, blowing his nose. He's got some tears. He's got goosebumps. He's complaining of really bad muscle aches. He says his pain's only getting worse. He's getting really anxious and restless. His legs are kind of shaking. You go in the room, he's got his eyes closed. He's sort of in a fetal position, turned on his side, curled up. He's really anxious. He's kind of getting ruder, having some diarrhea. Maybe he's vomited, and one of the blue emesis bags are on a chuck on the ground. Just doesn't look great. Oh, about to sneeze here, excuse me. All right, thanks. Okay, so there's a COWS score, just like we use CWA all the time for alcohol withdrawal. There's the COWS score for opioid withdrawal, and all those symptoms that we mentioned are part of it. There's also lots of subjective questions, things that you actually ask the patient themselves. So when I'm calculating someone's COWS, I pull it up on my phone, I go into the room, and I ask them, I scroll through and ask them the questions. How agitated are you? How anxious are you? How bad is your abdominal pain? It's pretty subjective, but at least it gives you an idea. And if the inter-rater reliability is not excellent, but if you're the one reassessing them later, then at least initially when you're treating these patients, do your own COWS score, don't necessarily rely on the nurses to do it for you. I think it's important for us to be able to recognize what it looks like. Just because someone uses opioids doesn't mean they necessarily have opioid use disorder. So here's a reminder of the DSM-5 criteria. As ED physicians and hospitalists, we don't often use the DSM-5, but to meet the diagnostic criteria for OUD, you have to have at least 2 of these. And that's not very hard to do. It's not very hard to have 2 of these findings. Just tolerance for opioids and withdrawal is enough to have opioid use disorder, unless the tolerance and withdrawal is due to you just taking your medications as prescribed. So if someone's prescribed morphine for their cancer pain, and they have withdrawal intolerance, they don't meet the criteria. But once their use starts to become a problem in their life and they keep using despite harm, that's really when someone has opioid use disorder. So you don't really have to go through all of these, but before I start someone on treatment, I do want to make sure that they meet the criteria somewhat. So if it's becoming a problem in their life and they've tried stopping and haven't been able to before, there you go, you've got your criteria. Okay. Then your nurse comes to get you and says, hey, the patient in room 12 is now trying to leave against medical advice. And how many of you have seen this, right? You've got someone who uses fentanyl, you're treating them for something else they've come in for, and then they leave way too early before any of their treatment is completed. This is very common in people who use drugs, especially when their substance use is not treated. So what do? I have seen all of these options play out. You could just treat symptomatically. For the ED docs, sometimes they just call the hospitalist because, hey, they're admitted now, not my problem. You let them leave because now it's just an easy dispo, someone maybe you didn't want to deal with anyway. You write them a prescription before they leave. You start medications for addiction treatment. So you're going to start buprenorphine or methadone, or you only want to start that if they actually want to quit. All right, so I've seen all of these play out, and I'm hoping that after this talk that you'll opt for option C. So you'll start them on medications for addiction treatment, regardless if they say they want to stop using or not. Because once they come into the hospital, once they get started on that, 50% of people do continue after they leave. So people are more interested in continuing once you get them started. If you can get them started, you can set them on a pathway to sobriety. That's huge. People feel so much better when they're properly treated on medications for addiction treatment. I've had people tell me I feel normal for the first time in years. I have people tell me I use fentanyl so many times a day, I no longer get high from it. I'm just doing it to prevent withdrawal. And now with Suboxone, I finally feel normal. Thank you. I've had patients so grateful for this medication, more so than anything else I do in the emergency department. If I splint someone's bones, their broken bones, they say thank you, but whatever, they don't really care that much. If I admit them for pneumonia, they're like, whatever. But when I start people on Suboxone, that's when people actually hug me. That's when people tell me that their lives have turned around. It is such a meaningful thing to start. So for all of you who might be experiencing some burnout from time to time, this is an excellent antidote. And going on to the big picture, to epidemiology of opioid use disorder. So intentional injuries were the #4 leading cause of death in 2020, and fentanyl overdose is the majority of those. So if you take out just the fentanyl overdoses or opioid overdoses, it's the 7th leading cause of death in the US. So this is huge. This is a real medical problem with lots of morbidity and mortality. But I would argue that in our hospital system currently, we don't really treat very well. We treat everything else. We treat heart disease, we treat diabetes. Even if people are going to keep eating sugary foods or not exercising, we treat it anyway. We treat the manifestations of these chronic diseases. But for some reason, the culture is not there to do that for substance use, even though we have excellent treatments. And so why should we do it in the emergency department and the hospital setting? That's where the patients are. They're coming to us. Either they come after an overdose, they come because they want to quit using. I'm also an EMS medical director, and I read lots of EMS run reports for patients who are transported from the field directly to the emergency department because they want to start treatment. And other patients are coming in with other things. They're coming in with their broken femur, they're coming in with cellulitis, they're coming in with endocarditis or sepsis. They're coming in to deliver a baby. And while they're there, you can also treat their substance use and you can screen them. You might be the very first person who ever screens them for substance use disorder. Also, I would say, traditionally, we have said that substance use is a problem for the courts. It's a problem for psychiatrists. It's a problem for behavioral health. Maybe it's a problem for rehabs and methadone clinics. But I don't think the siloing has worked, right? Our opioid epidemic has only gotten worse. It's hard for patients to get into treatment. Some treatment facilities have several weeks. They have to wait several weeks before they can get in. They might have to have a certain type of insurance to get in. Intakes at methadone clinics can take 4 hours. When someone's ready to quit, if they're in front of us, it's a perfect time to meet them where they are and start treatment before they change their mind. Unfortunately, it's so much easier for our patients to access fentanyl than it is to access treatment. And so when we do treat people for opioid use disorder, it improves hospital outcomes. So we do see these patients with opioid use disorder, more than 7 times likely than people without disorder to be hospitalized. So we see them. Untreated pain with undiagnosed opioid use disorder leads to premature discharge, worsening of other medical conditions, readmission, relapse, overdose. Opioid withdrawal can interfere with your medical treatment. And if untreated, it's a high-risk period that's associated with overdose and death. So people check out AMA and then go use again, overdose. Almost half of patients with opioid use disorder are interested in that, especially when they're in the hospital setting. And even that for short periods of time increases survival. So even if they leave the hospital and don't continue, you've given them a taste of sobriety, and every time they do that, their chance of recovery is higher. Starting medications reduces AMA rates. So that's good, right? Our hospital administrators like to hear this. And there's lots of organizations that support emergency department and hospital buprenorphine. There's the American College of Emergency Physicians, AAEM has a great white paper on it. The US Surgeon General mentions this in their 2018 report. The National Institute of Drug Abuse, SAMHSA. I looked for guidelines from AAFP and Society of Hospital Medicine. And although I did not find clear consensus statements, they do have lots of resources available that support ED MAT. And I would argue it's a standard of care. So yeah, standard of care is just when we're treating people with diabetes, we give the medications for that. When we're treating people with opioid use disorder, we should also offer the treatment. So what's the treatment? It's medications for addiction treatment, and I'll primarily be talking about buprenorphine and methadone. So let's just go first to methadone, because we're all pretty familiar with that. That's a full agonist, just like morphine, just like heroin. The more you take, the more of an effect there is, more respiratory depression, more CNS depression, more pain control. That's why it's more highly regulated, because it is possible to have a fatal overdose of methadone. So patients have to go to the methadone clinic every single day to get their dose. For buprenorphine, it's a partial agonist, so that there is a ceiling effect. It's a partial agonist with a very high affinity for the mu-opioid receptor. It also affects the kappa receptor, which has some properties around treating insomnia, anxiety, and depression. So that's pretty helpful. So it's a partial agonist, meaning the more you take, there will not be more of an effect. It is very hard to have significant CNS or respiratory depression when you give people Bupe. I had a patient the other day who came in for precipitated withdrawal. We almost gave 100 milligrams of buprenorphine in the emergency department, which is a very high dose, but they were not particularly affected by it. They were not particularly somnolent. The time it does become dangerous is if you're co-administering benzodiazepines. So be careful giving Bupe with the benzos. If someone's in bad enough withdrawal, just give them the Bupe, and they won't need the benzos for their agitation. The Bupe will take care of it. When choosing which agent to start for somebody, in general, I try to start Suboxone because it's easier to go from Bupe to methadone than the other way around. Patients don't have to go every day to the clinic. They can just get a weekly or even a monthly prescription for buprenorphine and they take it at home. So I feel like, and it's also safer. So I feel like it's safer. It doesn't interfere with many medications. It doesn't have a QTC prolonging effect. You can get it at any pharmacy. So I try to start with buprenorphine, but some people don't want buprenorphine. They say it doesn't work for me. I don't want to try it. I want methadone. So when people aren't sure which one they want, I kind of try to steer them towards Bupe, but if they want methadone, then we go with methadone. But just make sure that people know that they do have to go every day to the clinic. And in Cochise County, there's only CMS in Sierra Vista. So your patient won't have to go to Sierra Vista every morning, and their hours, I think, are 4:30 to 11:30 in the morning. It's the same thing in Santa Cruz County. I know this is going to be recorded, and we're going to have some viewers in Santa Cruz County. Same thing. CMS is the only methadone provider in the whole county, and they are based in Nogales. In Tucson, we have a lot more options. So here's a graphic that I like. So the line that's going down is overdose deaths, and the bars that are going up is the expansion of methadone and buprenorphine. And although we can't say that causation equals correlation or correlation equals causation, it's a pretty nice visual, right? So once we start offering treatment for opioid use disorder, overdose deaths go down. And this was in France. There's another cool study that I like that came out of Sweden, maybe it was Switzerland, and it started patients on buprenorphine. They randomized people to Bupe just for a week and then tapering off to abstinence. Or actually, I might have a chart on this. So hold on, let's hold this thought. Okay, so what about abstinence? I get this question a lot. I get this a lot from patients too. They don't want to be on medications. They don't want to be on buprenorphine. They don't want to be on methadone for the rest of their life. They just want to stop using fentanyl. And that's really nice. But unfortunately, for lots of people who have opioid disorder, it's not very effective. When people are just try to do abstinence-based therapy, many relapse and many have fatal overdoses. So this is a practice statement guideline from Canada's Medical Association. And they have a very strong statement that medications for addiction treatment are the standard. So I don't recommend abstinence-based therapy for most people, especially if they're coming into the hospital with severe complications. I recommend that people stay on that for at least 2 years before they try to stop. Here's the chart I was talking about. Okay, so this is a great study. And one of the authors, Creek, is actually one of the founders of methadone maintenance. So that's cool. And so this was in Sweden, and they randomized, it was a small study, all right, but they had 20 people in each cohort. One cohort got buprenorphine every day, I think it was 16 milligrams a day, and the other group got a taper. So they started out on Bupe, and then they tapered to placebo. And both groups had really robust behavioral therapy. So you're kind of studying what is just behavioral therapy with abstinence versus behavioral therapy with buprenorphine. And as you can see here, the group that was in the abstinence group, they all dropped out of the study within 2 months. Nobody kept going to treatment. And time in treatment is really correlated with survival. So everyone drops out of treatment, many of them relapse, and 4 out of the 20 actually die within the year. So that's pretty wild, right? 1 out of 5 of these patients died when they're abstinence only. Whereas in the buprenorphine group, nobody dies, and the majority of patients stay in treatment. So win-win. Here's the landmark study for studying buprenorphine in the emergency department. Gail D'Onofrio, the former chair of the emergency department at Yale, and she randomized patients to either just getting a referral. So, hey, here's your referral to CMS, follow up with them, or ESPERT, which is sort of this, it's a term used in addiction, but not really frequently used in emergency medicine. You sort of screen, you do a brief intervention, and you refer to treatment, or you do those things, plus you give Bupe. And you can see that when you're also giving that, 78% of those patients were still receiving addiction treatment within 30 days, compared to 37%. And in our rural areas, I imagine that the amount of patients who are following up with that referral is probably even lower, because there just really aren't that many services. And they have to travel really far to get them. So here's a question that I get all the time. Okay, this is great, Melody. You know, it sounds all nice and stuff, but are we actually allowed to do this? Our hospital is not registered as a methadone clinic. Is our hospital going to get in trouble with a DEA? Am I going to get in trouble with a DEA? I get that question all the time. And I'm not going to promise that the DEA, I mean, okay, that's a whole other topic. But anyway, yes, we are allowed to do this. And it comes out of the Code of Federal Regulations. So this is the exact place where it comes in federal regs that gives us the authority to start buprenorphine or methadone in the emergency department and in the hospital setting. This is kind of wordy. Don't try to read it right now, but just know that this exists. So if you ever get any pushback, you ever get any questions, you're worried, your medical director is worried, here's the stuff that lets us do this. The summary is, the first part is called the 3-day rule. So the first paragraph here is what we call the 3-day rule. So patients can come into the emergency department every day for up to 72 hours to keep getting a dose of buprenorphine or methadone to treat withdrawals. They come into the ED, they say, hey, I want treatment for my opioid withdrawal. I have not been to a methadone clinic before, but I want to start. So we start them in the ED, and we can do that for up to 3 days before they have to follow up with whatever other clinic they're going to. And the second part applies mainly to our hospitalist group. And this is that we can treat anyone with buprenorphine or methadone in the hospital for as long as they are there, as long as they come into the hospital for something else. So their primary diagnosis for admission or OUDs is pneumonia, it's the humeral fracture, it's complicated pregnancy, it's depression, it's something along those lines. Then you can start, titrate, whatever you're at. Just don't put the withdrawal as diagnosis number 1, because we are not registered as detox centers. So really, this is just allowing us, because if we don't treat our patients with MAT, we're not going to be able to treat their primary medical problem. They're going to leave against medical advice, or their pain is not going to be controlled, or they're going to be hard X, Y, and Z. You get the picture. So it allows us to treat their primary medical problem for which they're being admitted. Okay, so we can do it. It's the bottom line. Here's a list of resources. So you'll hear my talk, you might be excited, and then you'll forget about it, and you'll have a patient who's in withdrawal, and you'll think, oh man, what was it that Melody said? So go to cabridge.org. And I worked with lots of the doctors who were involved in making these protocols. They're very evidence-based. Every single protocol has a list of sources at the end and citations. There's about 100 protocols in here. So anything you could possibly want is here, and then some. So pregnant patients are in here, starting methadone is in here, starting buprenorphine in various ways. It's all in here. And so I'm going to go over a couple of their protocols. And for those of you at Benson Hospital, Dr. Turan has put up a few of these protocols in the ED doc box area. So they're easily accessible, and he modified it to make it more representative of what happens at Benson. Okay, let's start with methadone. This is actually the easiest. So for patients who are starting methadone, get that EKG. So you have the QTC documented. There's not really a number that I don't start methadone for. It's just good practice to have it documented. Although we know that methadone prolongs the QTC, we're not really sure if it has a clinical effect. We don't know if it actually means that it causes arrhythmias. So, and it's not dose dependent. So it's not actually that clinically useful, but it's nice to check that box. So get your EKG. So the initial dose, if someone wants to start methadone, I usually start them on 20 or 30 milligrams a day. If they are obviously high, I do not start them on that high of a dose. They might do 10 milligrams, but it's slow to act and long acting. So even if someone's high, I'll start them on 10 milligrams. But if they're withdrawing, I start them on more. I'll start them on 30 milligrams. And the max dose that you can give on day one is 40. Okay, so don't go above 40 milligrams on day one. And this is all federally stipulated in Code of Federal Regulations, Section 8. So they get started on the methadone. You start them on 20 or 30 milligrams on day one, and then you keep going up. You can go 5 to 10 milligrams a day. And then I slow down around 80 milligrams because it takes a few days to know whether a dose is going to hold somebody or not. And it's very simple to know if a dose works for somebody. You just ask them, are you having withdrawal symptoms? If so, how many hours before your methadone dose? Okay, if it's a lot of hours, they're going to need more. If it's just 1 or 2, you're almost there. And how about your cravings? Ideally, they will have no cravings and they will have no withdrawal symptoms. So keep going up. But so I usually start at 30 milligrams. I go up 10 milligrams a day. And then I slow down around 60 or 70 milligrams if someone is methadone naive. And then I spend a few more days at each dose before I slowly go up. If somebody's been on methadone before, you just ask them, what dose were you stable at? And then you go 10 milligrams a day up to that dose. Most patients stabilize from 80 to 120 milligrams. So methadone is actually pretty simple. Most people are not familiar with using it, but it's pretty simple. And the biggest thing is let the patient be your guide. Ask them if they're having withdrawals, if they're having cravings, and titrate appropriately. Okay, starting Bupe. So here's the fun part, starting buprenorphine. So because it is a partial agonist with a higher affinity than most other drugs, you want someone to be in slight withdrawal before you start it. That being said, there are protocols you can use when people are not in withdrawal. I don't have time to get into that in today's presentation. There are protocols on that cabridge.org website for micro inductions and cross tapers. There are ways to do it pretty simply. If you email me, I can also talk to you about it. If you call me in real time, I can talk to you about it. The OR line can probably help you too. But anyway, so here's the simplest case. The simplest case is your patient is in withdrawal, either because they haven't had their opiates recently or because they were given naloxone by a police officer or by EMS or wherever, a family member. So you get a COWS score, and this is the easiest way to remember. If their COWS score is 8 or above, give 8 milligrams of Bupe, and it's sublingual. Okay, so they don't swallow it, and they can't have any food or drink for at least 15 minutes after they put it under their tongue. Reassess them 30 minutes later. If they are feeling a little bit better, if they are feeling normal even, give them another 8. I like to load people at a minimum of 16 milligrams in the emergency department. 16 milligrams a day is a very standard dose of buprenorphine for people. And once you start doing this more, you'll realize that you can give even more and they're not going to be sleepier. There are some advocates and proponents that want us to start even higher doses in the emergency department, up to 32 milligrams in the ED. And for the traditional addictionologists out there, they're going to be they're like, what? 32 milligrams is so much. But it's not really. The clinical effect is not that different. And it'll hold, ideally, this has not been proven in a study, but theoretically, it'll hold the patient for a longer amount of time. If you just give someone 8 milligrams in the ED and they look better, so you think you don't need to give them any more, a few hours later, once they get home, they're going to be withdrawing again. So the idea about giving a higher dose is that it will last them longer. So I've started giving more. I used to just stick at 16 milligrams a day in the ED, but now I I usually give 24 milligrams a day, and some people even go up to 32. There was a study in JAMA Online in 2021 that showed how safe that was in the emergency department setting, which I would say correlates with the inpatient setting as well, because these people are being monitored. But even if they're being discharged, it's safe, right? The ED study shows that. So, okay, I'm waiting. Here it is. Here's the study I was talking about. So this shows that giving up to 32 milligrams in the ED was not associated with any more rates of respiratory depression, any more adverse effects, any more precipitated withdrawal. So you can give up to 32 milligrams. I like to think of it as when you see someone in withdrawal, their cup of receptors is empty. You know, we talk about a cup of empathy a lot. I feel like in emergency medicine, how your cup of empathy today? Is it full? Is it not? Like their cup of receptors is low when they come in withdrawal. And if you give a lot of Bupe, you're just refilling their cup. And so it makes sense to me that for induction, you would give more than you would on a standard day, right? You give a lot on the first day, and then their cup is normal, and then you just maintain that with subsequent doses. So now about the subsequent doses. To prescribe buprenorphine, you still need an X-waiver. If the MAT Treatment Act passes in the next legislative session in Congress, that might change. But at this time, the X-waiver is still required. And it's very easy to get one. You no longer need those hours and hours of training that used to be required. Now you can just Google SAMHSA buprenorphine waiver, apply, and you go to their website, the apply for a buprenorphine X waiver is bolded, click on it. You'll get to one of these screens. And there's a few questions that sometimes confuse people when applying for this form. Most of my viewers today are not board certified in addiction medicine, so you'll say no there. And you will say no, so you're not practicing at a methadone clinic, you're practicing at a hospital, so you say no. And you're going to say that you want to apply for the 30 patient level with exemption. So that means no hours and hours of training is required. All you have to do is click these boxes and you'll get your X waiver. It does take a few months to come, however. There's another question, like, do you work at a federal facility? So unless you work at the VA or IHS, that doesn't apply to you also. If you don't know the answer, it's usually no. I would recommend only applying for 30 patients. If you want more patients than that, you have to do the 8 hours of training for doctors. I think it's 24 for APPs. So you just want 30 patients. And what does that mean? What does it mean to have 30 patients at one time? That's 30 active open prescriptions. So if your prescription starts today and it's a week long, in 1 week, that will no longer be one of your active patients. I would recommend you keep a log of your X waiver or the patients you prescribe buprenorphine to, just in case the DEA does come and want to do an audit. You want to be able to show, here's the patients I prescribed buprenorphine for. And you also want to update your PMP. You want to update once you get your X waiver, update your PMP profile to include your DEA X, and then you can see all the prescriptions you've written. And the DEA recently, I think 2 days ago, and today is November, for those of you watching later, they just sent out an email, or the PMP did, that they're going to start auditing providers and making sure that people who are prescribing buprenorphine do have access to the PMP and do occasionally open it. So make sure your PMP and your X waiver are linked. So when I write maintenance prescriptions, I used to just write a week at a time. Now I'm doing 2 weeks at a time because it's hard to get into outpatient treatment. So I usually just write 8 milligrams twice a day, and I do the combo product. So this is for Suboxone. I do 8 milligrams twice a day for 7 days. This can be titrated up or down later, but this is usually enough to keep people stable in the short term. And this comes in tabs or films. And on your prescription, make sure you put your X number into the comments to the pharmacy. For patients who you see who are not yet in withdrawal and you discharge them before they go into withdrawal, you can still give them the prescription for Suboxone and tell them how to start at home. So one of our prior fellows wrote out these instructions, but cabridge.org has similar ones, which is guide someone how to start their Suboxone at home. So they wait until they're having some withdrawal. They wait several hours since their last use, and then they cut up their 8 milligram film or tablet, put half of it under their tongue. They wait 30 minutes and they take the other half. And then they just start doing 8 milligrams BID. And I should mention for the folks, for the hospitalists specifically, who'll be maintaining people on buprenorphine in the hospital, just like with methadone, you titrate to effect. So initially you have someone on 8 milligrams twice a day, but if they're still having cravings, go up to 3 times a day. And if you have someone who is on buprenorphine who also has acute pain needs, I'd recommend giving Dilaudid. You could do PO or IV, but it has a high enough affinity to sort of overcome the Suboxone. You can also go up on the Suboxone for pain needs. So you could go up to 4 times a day, 8 milligrams 4 times a day, but I wouldn't go up above that. If you have any questions about cases or about follow-up, you can call the OR line, the Arizona opioid line. It's open 24/7, and they should be able to answer your questions. Linkage to care. For those of you in Cochise County, there's Community Medical Services in Sierra Vista, which has methadone and buprenorphine. There's also the FQHC, Chiricahua Community Health Center, and they offer buprenorphine. And they have a direct line. So this phone number is their line to their MAP coordinator, and she will get people in right away. And they will also offer bridge prescriptions. So if you start someone on Bupe in the ED, you don't have your DEA X waiver, call this number and then one of their doctors or providers will send in the prescription for your patient sight unseen. It's a very cool service that they offer. There's also Community Intervention Associates. So I don't believe that they have methadone or buprenorphine, but they're intensive outpatient programs. So when you're discharging a patient, if they want a little more help, if they want to be kind of in a residential program or go several hours a day for groups and counseling and therapy, here's a place to refer them to. And for people who are not interested in stopping, there's Cochise harm reduction. So even though we're talking about getting people treatment with the goal of them to stop using, not everybody wants to stop using. Not everybody is going to be able to stop using. And so we have to make their use safer, and harm reduction is a way to do that. So they give out Narcan, they give out safe use supplies, fentanyl test strips. Cochise harm reduction is an excellent resource, and they work in the towns all throughout Cochise County. And in your discharge paperwork, please put down how much Bupe or methadone they got in the hospital so the patient can take that with them to the methadone clinic. So if you've got someone that you had on 120 milligrams of methadone, please put that in the discharge papers so they can be started right away in that 120. Otherwise, they'll be considered a new patient and bumped down to 30 milligrams again, which will be subtherapeutic. Here's a flyer on Chiricahua's MAP program. Susan Rich is their coordinator. She's very engaged. Please reach out. This is an excellent resource for our folks in Cochise County because they have clinics all over the county. Again, please use the QR code to complete your survey to get CME. I'll come back to this slide, but for the folks viewing in other counties, Santa Cruz County, Hope is a good referral source. You can leave voicemails, HIPAA compliant voicemails on this line, and there's a peer outreach worker who will follow up with your patient, see what services they're interested in. You know, to go to a methadone clinic, you have to have a state recognized ID. So Hope will actually take people to go get that ID. If they don't have it, they'll drive people to their appointments. They'll get them into rehabs if that's what they want. So they really work with the person and the individual, see what they need. Community Medical Services, again, is the methadone clinic in Nogales, and they also offer buprenorphine. And there's Mariposa Community Health Center, a federally qualified health center that is primary care, but also does buprenorphine. If your patient is not yet a member of Mariposa, there is a bit of a wait to get in. So in those cases, I recommend Community Medical Services for your MAP referrals. And then in Pima County, we have a lot more options, being a more populated area. So for harm reduction, we have lots of potential referrals. There's Sonoran Prevention Works, which is actually the biggest distributor of Narcan in the whole country, which is pretty cool. There's Southern Arizona AIDS Foundation and Church of Safe Injection Tucson, which actually does home delivery of Narcan and kits and supplies. And patients can find that via Facebook, Church of Safe Injection. They message them on Facebook. For methadone and Bupe clinics, there's Kodak, CMS, Cope, La Frontera. There's a Pascal Yaki clinic, New Beginnings. So just refer to whichever clinic is closest to your patient where they are staying. And Kodak is 24/7 and patients can just walk in, which is pretty cool for intakes. And El Rio is our FQHC that offers buprenorphine. They have a really robust MAP program. So again, please fill out this QR code to get your CME, and thank you for your time today.